Okay. Thank you very much for this invitation. Good afternoon, everyone. My name is Türk, pulmonologist, somnologist, and I work at the Erasmus University Medical Center in the Netherlands. Today, I'd like to share with you a fascinating fact about DMD and sleep. Why does DMD patients experience respiratory complications? Well, I'm here today to share some insights on that. I have 20 minutes and not so much slides. First, ventilation can be impacted during sleep through a variety of normal sleep-related alterations. One is decreases central neural output, drive to breathe, you know. Two, a shift to greater ventilatory burden on the diaphragm during rapid eye movement sleep due to reduced contributions from the intercostal and accessory muscles. Increased upper airway resistance, decreased chemosensitivity, decreased responsiveness to hypoxemia and hypercapnia. And 5, oxyhemoglobin desaturation and hypercapnia. The consequences of these alterations on healthy adults and DMD are discussed in this presentation. Central neural output is very important. Fail to maintain a normal level of ventilation when the central neural output decreases during sleep. This is clinically inconsequential in healthy adults, but can be detrimental in patients with a DMD because they rely on an increased central neural output to compensate for weak ventilatory muscles to maintain their increased work of breathing. Diaphragmatic burden increases. The burden increases during the sleep. Inspiratory intercostal and accessory respiratory muscles activity increases during non-rapid eye movement sleep compared with wakefulness. But the activity of the diaphragm remains unchanged. By contrast, inspiratory intercostal and accessory muscle activity decreases during rapid eye movement sleep, while diaphragmatic activity increases. This shifts the burden of maintaining ventilation to the diaphragm during the rapid eye movement sleep. The increased diaphragmatic burden does not have significant clinical implications in healthy adults. However, the patients with the DMD may have a weak or mechanically disadvantaged diaphragm that is incapable of overcoming this load. This increases the risk of hypoventilation during rapid eye movement sleep in these patients. These findings emphasize that hypoventilation is typically manifested first in the stage rapid eye movement sleep. Upper airway resistance may increase during normal sleep compared with wakefulness. Immediate load compensation, the physiological changes cited to maintain normal ventilation in presence of increased upper airway resistance decreases during sleep. The combination of increased upper airway resistance and reduced ventilatory muscle function may lead to hypoventilation during sleep in patients with DMD. A sleep study with a capnography should be obtained at any stage for patients with an excessive weight gain due to glucocorticoid therapy to exclude sleep apnea, or for those with the symptoms of sleep disordered breathing. Chemosensitivity ventilatory responsiveness to both hypoxic and hypocapnic chemostimulation during non-rapid eye movement sleep and rapid eye movement sleep. Normal sleep is associated with changes in the ventilatory responses to chemo stimuli. Hypoxia and hypocapnia combined with reduced ventilatory muscle strength. These changes enhance the risk for pathological hypoventilation during sleep in patients with DMD. The ventilatory responses to hypoxic and hypocapnic chemostimulation is decreased during non-REM sleep compared with wakefulness and less during rapid eye movement sleep. These changes may predispose patients with the DMT to substantial ventilatory and/or gas exchange disturbances during sleep. Oxyhemoglobin desaturation is likely cause of abnormal decreases of saturation during sleep. Abnormalities in oxyhemoglobin saturation during sleep may be accentuated in patients with a Duchenne muscular dystrophy. The decreased oxyhemoglobin saturation is most pronounced during rapid eye movement sleep. Decreased tidal volume was associated with oxyhemoglobin desaturation during sleep. Other etiologies, including ventilation perfusion mismatching, is also a possible contributor of desaturation during the night. Hypercapnia, sleep-related hypercapnia may itself contribute to awake hypercapnia. This occurs because persistently elevated PaCO2 during sleep may lead to increased serum bicarbonate and buffering capacity, which persist into wakefulness. Nocturnal hypoventilation in persons with DMD not only occurs in the absence of awake hypercapnia, but also can be present in the absence of concurrent nocturnal hypoxemia or awake symptoms of nocturnal hypoventilation. Recording of sleep thus can facilitate early identification of hypoventilation during the night. I would like to thank you for your time and attention this afternoon. I had 20 minutes, that's why I have a short presentation for today. Are there any questions?